Good morning, everyone. So today is the day when our Data and Donuts is going to be dedicated to the data science for social good projects. So first off, I think I want to congratulate our two teams that have worked hard over the last 8 weeks and through all kinds of challenges they've had. And I also want to take this moment to sort of thank the people behind the scenes who have made a lot of this possible. First off, a great shout out to the mentors, Yiting and Haojie. I think they've really done the lion's share of the work. And together with Noah Cohen, who's actually helped being the point person on a lot of statistical questions and so on. So a big hand to all three of them. And I also want to thank the Stanford Data Science for making this possible. I mean, the team, Maddie, Lynn, and of course, Chris also has been behind the scenes making all these things work. And I think today you'll hear about two projects. I'd be remiss if I don't thank the faculty leads on these projects. So for the first project, we had Isabella Chu from the Population Health Sciences, the eDaily project, which you'll hear from today. And for the second one, we had Haojie's advisor, our host, Pascal Gelselser, who's actually in the School of Medicine here. So without further ado, I think I'll hand it off to Haojie, who will introduce the.
Yeah, the first presenter gonna be our team. So without further ado, let's just I'm gonna refresh it again just in case. Yeah, okay.
Hi, hello. We are the Global Health from Space team. That means we have been working on predicting various health indicators from satellite imagery and remotely sensed variables. I'm Ness. I'm a rising senior in the data science and social systems major.
Hi guys, I'm Allana. I'm a rising junior, also in the data science and social systems major.
Hi, I'm Esha, and I just graduated from that same major. So to echo what Naras was saying, we've had the opportunity to work with some really amazing people, Haojie, Naras, Noah, throughout this summer. And also we have our wonderful faculty advisor, Pascal Gelselser. So thank you so much, Paul. Right, so to set the stage for what we researched this summer, we'll start with an overview of some of the challenges that global health data faces. So global health data primarily depends on these household level surveys where people come to these households in these countries, knock on their doors, gather a bunch of economic, demographic information. But the issue here is that conducting these surveys in these areas where they're often most needed is very rare and costly. So on the left, you can see the map shows how rarely these nationally representative economic surveys are conducted. So in many countries, especially in parts of Africa, surveys happen only every so often or sometimes not at all, which leaves gaps in our data. And for the scatter plot on the right, this shows that countries with lower GDP per capita tend to have fewer surveys overall, meaning that the places that need these surveys the most may not be getting them.
So in addition to the fact that surveys are conducted extremely infrequently and that they're difficult to conduct in middle and low income countries, when these surveys are conducted, the way that DHS surveys households within clusters, they typically survey an extremely small portion of the population, and it's typically less than 2%. And then the last challenge we'd like to draw attention to is the fact that policy changes can have major impacts on data availability. For example, on March 10th of 2025, 83% of USAID programs were cut, and this includes DHS. And then as well, on July 1st, all USAID offices were closed officially. So yeah, we just want to shed light on the fact that our model can potentially fill gaps where data is unavailable, when survey data is unavailable. So there is a growing body of research suggesting that satellite imagery and other remotely sensed data can fill this gap with data availability and suggesting that it can help to measure livelihood outcomes where ground data is sparse. And then this graph just shows a sample of some of the satellites we have right now, and then how frequently they visit a given place in Africa, and then the granularity to which the photographs are taken.
And so the project goal here, just summarized, is to use remotely collected satellite data to predict maternal and child health outcomes in low and middle income countries. And so to talk a little bit about what we're going to talk about today, we just got finished up with our project goals. We'll introduce you to some of our data sets as well as some prediction scenarios to kind of ground some questions, our model in some real world use cases that we may have. We'll talk about our pipelines a bit and then future stuff.
So first, we're going to introduce you guys to our data. We have three main data sources: DHS survey data, which we're using as ground truth data; GE data, which is Google Earth Engine data. It's a big repository of geospatial data; and then lastly, the satellite imagery, as we discussed. So first, the DHS survey data. We have 180 surveys from 61 different low and middle income countries across 37 years. This is 1986 until 2023. We explored 5 indicators which are closely related to maternal and child health. These indicators are stunted rate, which is children who are under 5, who are less than 2 standard deviations from the World Health Organization's median health for that year. The second one we chose to explore is the under 5 mortality rate. This is the probability of a child under 5 dying within the 5 years preceding the survey. The third one is skilled birth attendant rate. This measures the percentage of live births in the 5 years preceding the survey, where there's a skilled birth attendant present, whether it be a midwife or a doctor. And the fourth one is the unmet need for contraception. This is the percentage of women who do not want to become pregnant, but do not have adequate access to contraceptive care. And then the last one is women's mean BMI in that country. So from the DHS data, we have data from 150,000 clusters across the 61 different countries. Each DHS cluster is made up of about 25 to 30 different households. In addition to that, we have a DHS ID to identify each cluster, the Latin Lange location of the cluster with a little caveat, as well as the year and the country of the survey, and different information about whether the country is urban and rural, and then as well as our indicators.
Speaking about the caveat with the Latin Lange, we have these cluster locations, yes, but they're jittered. So what that means is the DHS does that survey in that certain location and then actually randomly picks a location within a certain radius and then gives that actual location to us. For urban clusters, this is up to 2 since they're highly heterogeneous and very dense. For rural clusters, this is usually up to 5 kilometers, but for 1% of the clusters, it's up to 10 kilometers. So one solution to recover this original location is by snapping, because as it is, our current snap radius for rural locations is much wider than the radius that we have for within our satellite imagery. This means that we cannot guarantee for rural clusters that this cluster is in actually the satellite image. They may not be in the image. So we could snap them. One protocol that we follow uses something called the OpenStreetMap. Yeah.
Sorry, what is snapping?
Snapping is when we have this location that is given to us, we don't know where the original location is, and we try to find that original location. We try to essentially snap it there so that we can sample our data from that new location. One protocol that we followed was the OpenStreetMap, which is an open source map where people who live in that region enter data about where they live, the buildings there, their climate, those kinds of information goes in here. As you might see in the GIF, it is filled in over time. This means that it's incomplete, but for relatively well-populated places, it can be a good indicator for what is there on the ground. Another data set that we use to find potential places to snap to is WorldPop, which is a population data set. In doing this, we use nearest distance first. So we have a list of potential locations where this cluster could have come from, and we sort them by distance. We choose the nearest one. The other algorithm that we use is we look at these potential locations, we look at their populations, and then we choose the biggest population one. Happy to talk more about this later. So you might be like, Ness, there is no ground truth in the DHS data set, and that is true, but we do have ground truth in the OpenStreetMap data set. So what we did was we grabbed it, we sampled it like a DHS survey. For example, in Tajikistan, we might have something like 250 surveys. And so I sample accordingly from a random country, jitter it like DHS would have, and then attempt our recovery algorithm on it. Here it says population floor. That is because, as you might remember, household surveys contain 20 to 30 households. So that's like about 90 people. So if we consider a population square that has only 5 people in it within that kilometer, well, that's not a good choice. So we have various elimination pre-processing techniques. And then I essentially repeated this sampling method and recovery about 100 times to give us this gorgeous graph. You might immediately see, oh, what are all these lines? The gray line is what happens if we don't do any snapping. And the blue lines are 2 algorithms, with the light blue being population, dark blue is being distance. The red line is when the original location is in the satellite image. So that is recovery. And recovery error is we have our original location, it's been jittered, and then we have our recovered snap location. What is the distance between these two? That is our recovery error. So we are seeing immediately that our algorithms are actually spreading out our data. So when it comes to original location jitter, we seem to be recovering further away. So we're not necessarily guaranteeing that the original image is going to be in the satellite image. In fact, it's about half the chance that it used to be. So that's not great. However, we do have a pretty low unsnappable rate. So what that means is a cluster was not able to be snapped somewhere else. There are, of course, many caveats with this finding. There are many differences structurally between the OpenStreetMap dataset and the DHS dataset in how they can be sampled. For somewhere like India, it's very densely populated, but for a rural location somewhere else, our OpenStreetMap may not necessarily have that much data. So it's not going to favor our selection there, essentially. There's a high error rate. And also, world pop data isn't perfect. We're looking at kilometer squares, and that's pretty hard to get accurately. So it might not necessarily be perfect in those regards also. All in all, it's a pretty low unsnappable cluster rate, which is pretty interesting. Why are we doing this if this seems so low? Well, we have read quite a few journals. We've gone through quite a few articles over the last few weeks when looking at this problem. And a lot of papers report similar results. However, there is a paper that has reported an R-squared increase of up to 0.1. So that is a 10% increase in variance explained, which is quite a bit. So we're hoping that regardless of this, it might help us improve our model's performance, even though we're not actually recovering the original situation. So this is one thing that we want to test.
Yeah, and so moving past the DHS data a bit, another source that we're looking at is our Google Earth Engine tabular data. These are just extracted features from satellite imagery. They're remotely sensed variables, and these could be something gives us back something like the mean of the surface solar radiation, kurtosis of temperature, snow layer. Yes, that's basically.
And the last data set that we're using is satellite imagery, which is, as you might see, looks something like this. These are Landsat images that come straight from our data set from Bolivia, I believe. We have visible light, we have near and shortwave infrared light, thermal for Landsat and also night lights. Our models adjust for this difference in band number. The bands are what you see over there. And this is kind of what it looks like.
Right, and so now that you guys know a little bit about our data sets, we are going to talk about what we like to call prediction scenarios. So we've constructed 4 prediction scenarios that kind of simulate the real world situations where our satellite-based models could fill in gaps when it comes to health monitoring. So by testing our models in each of these scenarios, we can understand somewhat how well it performs when data is missing for certain regions or time periods or even countries as a whole. And these are exactly the type of gaps that people can face when they're working with this very scarce data. And so we're going to walk through a couple of visualizations here. This grid up here is showing what survey coverage can look like across certain countries and also years as well. The darker blue squares are showing where country year pairs are surveyed, and the lighter blue are showing where they're unsurveyed. So we know, for example, that we have information in Nepal in 2015, in Eritrea in 2016, and so on. So this brings us to our first scenario where we could ask ourselves the question, can we make predictions for countries that we have no data on within our DHS years? And this we would form something like country holdout, where we are training all countries except one.
The second application scenario we came up with was can we predict on future years? If DHS data is not yet available, it takes a while to come out. How well can our model predict what the health indicators will look like in a future year? So to simulate this, we held out the most recent years and then trained on earlier years.
And so those are scenarios where we don't have any information on like maybe a certain year or a certain country. But there are situations where we would like to do what we call within survey prediction, where if we look at the highlighted green cell, Nigeria 2018, we know we have some information on Nigeria. And generally how, as Allana mentioned earlier, how the DHS samples this comes up to about roughly 2% of Nigeria 2018. That's a very rough estimate, but generally we know we don't have all of Nigeria 2018's information. We only have a little bit of it. And so we can ask ourselves the question of, given 2% of women's BMI in Nigeria 2018, hey, we have some ground truth. How well can we predict all women's BMI in Nigeria 2018? And a split like this would look like a classic 80-10-10 split, but we need to be a little bit particular about our test set here. Next slide. Yes, because if we look at something like Nigeria 2018, there are cases where some clusters in Nigeria 2018 may have all 5 indicators, but there are also cases.
Just out of curiosity, so these are like when you're predicting like countries that you don't have data for or years that you don't have data for, it seems like you don't know how good your predictions will be. So like what is your test population, or are you subsetting the existing data you have?
We're just like doing a leave one country holdout. So like we take from the DHS data, we have like we can like, for example, we have Albania, but we just leave it out of our train, and that's how we're.
I see.
So it's like, oh, go ahead. No, go ahead.
There's one hashtag in the Albania one,
There should be one hashtag, or
like in practice there.
Yeah, yes. Like acting like we don't know Albania, but we do have Albania.
Oh,
and
I
that's
see.
how, yes. But like, yeah, we're trying to simulate these real world scenarios where like, and seeing like, hey, how can our model perform? And this is how we try to get a gauge of that. And we'll go over results later as well. So yes, to continue off, again, we're within survey prediction. So we know we have some information on a country year pair. And some clusters in Nigeria 2018, we know that we may have all indicators available. We may only have 4 indicators available. And so this is why we construct indicator specific data sets. You may notice in my question that I posed, I'm not saying I'm not saying I have all health indicators in a model. We're doing very indicator specific models. So we run a mean BMI specific model with our mean BMI specific data set. And in order to be able to fairly evaluate performance across indicators within Nigeria 2018, we have to construct a universal test set where we randomly sample clusters that have all indicators, and that becomes our test set.
So the last, oh, sorry.
You're good. And then, so that's like a country level task within scenario C, but we can also have a global level task where we can ask ourselves the same question, given 2% of women's BMI Nigeria 18, but now we add in women's BMI data in all other country years. How well can we predict all women's BMI Nigeria 2018? So just a few examples of these kind of knobs that we can toggle given like our available data that we have.
I have a question on, do you look at distributions of, say, women's BMI in the train, validate, and test?
That's something that we want to do very soon. Mhm.
So for our last application scenario, we wanted to ask the question, can we predict for a survey that was not conducted in a country or year, in a given country or year? So to simulate this one, we also had to construct a universal test set for all 5 indicators because as you can see here, we have 38 years of data in 61 countries, resulting in a possible 2,196 surveys if every country was surveyed for every year that we have data available. But in actuality, we only have 180 surveys. And for some of the indicators, we have even less. For example, like stunted rate, data only began being collected in 2004. And so there's vastly less data for that. Here is, for example, data availability for mean BMI. It's much more readily available as compared to data availability for an indicator like stunted rate. So for this application, we elected to hold out stunted rate and only keep the data sets where we have the most abundantly available data. And so from these 4 data sets, we had to construct one test set that we could use to evaluate across all indicators to see how they perform comparatively. And so to do that, we started with the 180 surveys that we had. We filtered it down to the 116 that had of the 4 indicators of interest. And then from that, we randomly sampled about 10% of clusters from the entire data set. It is about 7 to 10 total surveys, depending on how many clusters are in countries of the surveys. And then from the remaining surveys, there are about 90% left. Those are randomly split into train and validate. Now we're going to talk a little bit about our Google Earth Engine pipeline. This is the pipeline that uses the geospatial and environmental variables from the Google Earth Engine. And this pipeline really helps us understand how far we can get without the actual images and only looking at extracted features from said images. So we run this application across all 4 scenarios, but the core model stays essentially the same. And then we split up our training and tests differently to accommodate the different simulations. So first we have the GEE and the DHS data. That data is merged, pre-processed, and then our model makes predictions and outputs our predictions and metrics.
Well, let's talk a little bit about our results. There's a lot going on the screen. But basically scenario A, if you remember, is our country holdout task. And both of these maps are showing the R² performance across African countries for 2 indicators. The left map is showing mean BMI and the right map is showing a skilled birth attendant rate. And the darker colors are showing where we're performing the best, the lighter colors, not so much. Gray being, we don't have data on those countries. And so if we focus on one graph, we can see that the R² performance is really varies across different countries, but it can also vary across indicators as well. If you notice, Mozambique in that MC down there, and Nigeria do better jobs at oh wait, NC.
My bad. Yeah.
Yeah,
it's in the lower.
Yeah, down there. If you notice, Mozambique and Nigeria do a better job at predicting mean BMI compared to skilled birth attendant rates. The idea here is that they can vary across countries and performance can also vary across indicators. And then next, we're going to focus just on Nigeria as an example here. We have this moving GIF, but ideally, if you can catch the 2018 here, we'd like you to notice that our model has a bit of a harder time when it comes to capturing extremes. Generally, in this corner of the 2018, we would hope to see potentially more bright yellows and brighter oranges in our model's predicted values, but we seem to be tending towards the mean a little bit. So we can capture general tendencies well, but we do have a hard time with extremes for this model. And then lastly, for this country holdout scenario, across the African countries in the spatial holdout, we do find that skilled birth attendant rate and mean BMI are the most predictable indicators, while we generally have a harder time with our under 5 mortality rate and our unmet need rate. And this tends to be the case across the board in terms of what we find to be the most predictable indicators.
For our second application, we're running a little short on time, so we're going to speed through the next ones just a little bit faster. But in the year holdout scenario, our model performance declines compared to our other setups, suggesting that it's more difficult when temporal generalizations. Mean BMI still performed the most accurately with the R² of 0.42 and an RSME of 0.07. And while unmet rate shows the weakest performance, skilled birth attendant rate and under 5 mortality rate fall in between. And this really shows that there are varying predictive strengths across indicators.
And then we have the scenario where we have the within survey prediction where we know we have some ground truth in our train. And we see that we tend to do better. That's a little bit expected given that we've seen certain patterns before. And so we do see a jump in our R² here. So for this sort of application or this prediction scenario, the model does have an easier time capturing the relative patterns variation. It is worth noting that the normalized root mean squared error does tend to perform not so great, but yes.
And then for our last one, we tested our model with 10 different test sets, 10 different random samples for that test set. And then we found the average R² and average NRMSE for these models. And we can see that it performed again particularly well for mean BMI, having a pretty good R square and also a low Narasimhan.
Now let's run over the satellite pipeline. Very similar structure, except we're taking in satellite data to predict these outputs. Again, goes through a lot of data processing where snapping is again toggleable. In our models, we have various choices from visual transform, like various transformers, pre-trained again to pre-trained convolutional neural networks. I'll particularly be talking about ResNet 18 and 34 to essentially trial how our data would perform across different methods and different data sets. It then goes through a regress thread of 3 fully connected layers. That is the essential structure of how images are processed. So let's jump right into it. This is just the Nigeria 2018 survey. It is an 80-20 train test split. And immediately we're seeing that there's quite horrible performance on part of ResNet 18, but like a relatively acceptable performance from ResNet 34. We're seeing quite high error rates and fluctuating R squareds. Our model, this is not doing nearly as well as the G dataset. However, though we don't have enough data, once we add that, our performance increases quite a bit. So what we're seeing here is essentially, was there improvement from Nigeria 2018 when we increase our data set to all surveys available in Africa? So these are all the clusters in Africa that have been put through an 80-20 train test split. And we are seeing quite a bit of improvement, especially for ResNet 18, for everything but stunted rate. Stunted rate is weird. I was not able to get a good result with it on any of my models. But for the others, we are seeing much lower error rates compared to the GE pipeline on certain parts. And some of them have a higher R squareds. Let's compare data sets really quickly. This is just ResNet 18, Nigeria 2018, and Africa. So when we look at them, we're seeing that certain indicators really require an increase in data set size, and especially for a small model like ResNet 18, it's a relatively smaller convolutional neural network compared to the other models that we have. This data set is quite vital, but for something like ResNet 34, we're seeing that it can somewhat make up for the data set difference by being a bigger model that is also pre-trained, but not quite to the point where it outperforms, Nigeria outperforms Africa. However, we are seeing some fluctuation here, which to me says, hey, there's some decrease, for example, in performance when it comes to skilled birth attendant rate, which was actually one of the strengths of the G pipeline. We're not doing as well there. So perhaps there is some regional variance within indicators. Yeah.
Question on by Africa, you mean I'm taking in all the data for Africa throughout all the years, studying it 80-20, 80-10-10.
Yeah.
And the testing is, or the numbers for R2 here are for Nigeria in particular, or Africa, sorry, the last test split of Africa sample.
These are just test outputs. I'm not showing you any of the training R squareds or training error.
Gotcha.
Test errors. The right side is for the Africa run, where the data set was all of it, and then the right side, for you, the right side is just Nigeria.
Okay, because I just wanted to make sure, because the top left icon shows, I guess, Nigeria there, so it's okay, good.
The issue with that inspired Africa was when it came to application C, we were like, ooh, when we just do one survey, it doesn't seem to perform enough. And for time's sake, instead of doing the global version where we are just predicting online, this might have been a faster way of simulating its performance. Another reason is they are doing the cross-validation survey selection algorithm, and that hasn't been integrated fully into the satellite imagery pipeline yet. So the satellite imagery pipeline can't just be like, oh, let me pick this amount of Nigeria to run exactly what scenario C was. So it's kind of like a close enough approximation. Yeah.
Can I ask, what do you mean by pre-trained ResNet 34?
Oh, I get ResNets from like online essentially. These are pre-trained convolutional neural networks that I download online. They already have weights that are adjusted for processing images. So that just speeds up training by quite a bit.
I see. So what are the corpuses that they are trained on?
These are trained on ImageNet except for SatMe, which is trained on satellite images only. So yes.
So as Ness mentioned, these pipelines have not been integrated together yet, but this is a task for future work. We are hopeful that by combining these two pipelines, we can achieve better performance than both pipelines.
Here's what it would look like essentially. Where the tabular data would be processed within its own pipeline, the satellite images would be processed by their own pipelines, and then they would come together for the regression at the end, essentially. The non-tabular option still exists, the tabular pipeline still exists, they still exist separately, but we want to be able to bring them together. The model is already there, but for evaluation and visualization purposes, it's not done yet, which is why you cannot see any results today, unfortunately. But it is to be done.
So to conclude, as we just said, we'd like to combine our pipelines into one bigger pipeline to outperform both individual. Throughout both pipelines, mean BMI and skilled birth dependent rate tend to perform better than the other indicators. And this makes sense as we have quite a bit of data as compared to the other indicators for these two. And then in the future, we hope to combine these together, explore different models and how they perform, as well as implement different testable features like snapping or different downsampling of larger countries. And lastly, we'd like to integrate more DHS health indicators if available.
For the interest of time, let's just move to the next team. Both teams gonna stay after the presentation, so give your question to them and ask them.
You want your jacket?
You just leave it there for that. Well, we're 2 minutes.
So sweet.
Yeah. No, that's not.
That's going.
They're like work on print facing.
Oh, yeah, this is the best one. Yeah.
It's like
Okay, now is
they're like
time
trying
for
to.
our second presentation from the calculation team. Whenever you are ready.
Thank you, Haojie. Yes, we are data science on the road now, looking at car collisions and their overall effect on life expectancy. So first introductions, my name is Xander, hello. I am a rising senior in the mathematical and computational sciences track of data science and have been enjoying a lot over this summer, working on data visualizations and also working on making data queries and pipelines.
Hi, I'm Pankhuri. I'm also a rising senior. I'm in the data science with social systems major, specifically in the brain and behavior concentration. And I'm doing a minor with human. I'm very interested in like data science, healthcare, so I've also been having a great time this summer learning about that.
And we also would like to thank our faculty. Thank you to Naris, to Isabella, as well as to Yiting especially Yiting for meeting with us every day at 9 a.m. and helping us to figure out things like what comes next and I don't know, all those lovely problems that comes with data. Okay, so roadmap. We're basically going to do a general overview of our project and how we looked at car collision data. And then we're going to look more at the data specifically and see the general scope of the data and how car collisions are generally perceived and who tend to be in them and like more demographics behind that. And then we're going to look at the extent of how car collisions impact people who are in them, and then conclude with our final findings. So first, our motivating statement is that car crashes are the leading cause of death for Americans under 25 and account for 30% of unintentional injury deaths. So this is what the current literature has done. It has looked at people who are in car collisions and they die. What we want to look at is car collisions that are non-fatal and how they impact life in general. So our first goal was to expand on the current literature that's related to non-fatal car collisions. And then what we wanted to do is, again, create data visualizations to understand the scope of these non-fatal car collisions, and then estimate their total impact through disability adjusted life years, which is or we'll refer to as daily, which is a WHO metric that is used to understand the impact of a disability or injury on a life. Looking first at our data sets, my primary data set was focusing on Medicaid, which is rows comprised of claims made on behalf of a beneficiary. And the people who are represented by this data set are individuals who are 138% or lower below the federal poverty level. So it represents low income collisions, or people who are of low income in collisions. And the dates of my data set range from 2015 to 2019.
The data set that I was working on is the market scan data set, which is a commercial data set collected from various different sources like employers themselves and government data. So everyone who is enrolled in this, it has private healthcare, and these are all employer-sponsored plans. So everyone who's on it is either an active employee, one of their dependents, or an early retiree. So they tend to be higher income than the people in the Medicaid data set. And the dates here range from 2007 to 2022, so a much larger data set. And here at the bottom is a brief summary of how many claims we had per data set. So as we can see, the market scan data set, it's a lot bigger than the Medicaid data set. It's around 12 billion claims and around 243,000 collision related claims, which translated to approximately, I think, 1.5 million people being represented.
And then likewise with Medicaid, there was about 68 million claims, and about 30,000 of them represented actual car collisions, which is a question that we had from our data initially. Is this seems like a low number. And so we also wanted to explore kind of how these codes generally are coded. But also looking at variables of interest of our data set, we looked at the demographics, which are basically who people were using their beneficiary ID, their date of birth, age, state, sex, and then looking more at their visit, looking at the diagnosis codes, procedure codes, admission date, discharge date, et cetera. And then also looking at the total coverage about how money was spent in a visit, whether it was covered by Medicaid or if anybody had to pay out of pocket. And likewise with market scan.
And some of the other things that as we were going through our data set that we kind of made decisions along the way is that both data sets have inpatient and outpatient data. So looking at those, and we also specifically decided to look at California, Michigan, and Florida and compare those two states. So how do we even determine what's a collision within the data set? So each person has up to 12 diagnosis codes. Outpatients have up to 4 in my data set, and inpatients have up to 12 different diagnosis codes. And so these are ICD codes. So it stands for the International Classification of Diseases. Prior to 2015, they were using the ICD-9 codes, and afterwards they're using an ICD-10 code. So this is an example of an ICD-10 code. So the first letter is going to tell you, for V stands for vehicle code. And then afterwards, the next digit will tell you who was injured. So who was the patient that you're seeing right now? What role were they in? What kind of vehicle were they in? Afterwards, the third digit will tell you how they were injured, so what did they collide with, slash the nature of the injury. And this digit at the end will be an A if it's a first-time visit and a D if it's a follow-up visit to a previous injury. So for example, if we were to see someone with this code, we would see that it was someone who was either driving or a passenger in the car and they collided with another motor vehicle. This is an ICD-10 example, but ICD-9 codes are coded in a similar way, just a slightly different format.
So now that you guys kind of understand what these codes mean, let's look at the general scope of what was represented by our data sets. First, motor vehicle collisions by state. Both data sets kind of agree that California has the highest total amount of motor vehicle collisions. And then on the Medicaid side of things, it seems like Indiana was the second highest, as well as Michigan and some of those other states that are colored orange. And then what was interesting to us initially about the total spread of states is how little hospitalization data there was when it came to New York, which we found to be due to the fact that auto collisions are covered under a separate type of insurance. New York is what's known as a no-fault state, meaning that hospital injuries are covered up to a certain premium by auto insurance instead of hospital insurance or medical insurance. And so claims in New York oftentimes were not covered by Medicaid.
And here in the market scan, you can see a similar trend with California being the state with the highest number of collisions. But interestingly, some of the other states are different. So in market scan, the highest numbers were California, Texas, Georgia, and New York. So we didn't look into this too much, but we suspect that the differences are mainly due to the different places that the market scan data was collected. For example, they were only collected from certain insurance plans, which may tend to be more prevalent in different regions across the US.
In Medicaid, there was also a distribution of by race and ethnicity. And in California, it follows the same general distribution that the overall claims also followed. And then interestingly, looking at motor vehicle collisions by age and sex, if you look at the Medicaid chart, there's two arrows on the bottom here that kind of represent where gender distribution sort of peaks and falls. From ages 15 to 19 and then up to like the mid-20s, it tends to be more male drivers that are in hospital or collisions that lead to hospital visits. And then later on in like late 60s, early 70s, it switches to female drivers who are in more hospitalizations, which is interesting to think about because you can maybe reason it as like teenage men are maybe a little bit more reckless and maybe a little bit more likely to be in hospital collisions. And then for female drivers in late 60s, early 70s, it could be due to simply there being more female drivers, or it might be other, I guess, ideas for that as well. Another thing is to look at is the peaks of this data. Age data in both of our data sets, well, at least in Medicaid, followed sort of a bimodal distribution, peaking in teenage years of late teens, early 20s, and then also peaking again in the late 50s, early 60s, when people are just learning to drive and when they probably should stop driving on the road.
Yeah, here in market scan, we can see a similar trend. It's important to note that there's no one or barely anyone older than 65 in this data set, because at that point they become eligible for Medicare and they tend to move off these employer plans. So we don't have data for that, but we can see it follows a similar pattern where people between the ages of 15 to 24 tend to have the highest amount of collisions. Interestingly though, in all of my data, it's women drivers who tend to be in slightly more accidents.
So this is for all people that were in the car. Like this is not just the driver, presumably.
Yes.
Yeah.
Good question, because that is an excellent segue into what we looked into next, which was the injured person. So yes, when we looked at motor vehicle collision injuries, it wasn't just necessarily the driver. That's not necessarily how it's coded in these like insurance claims. What it is coded as is if they were in a motor vehicle or what they were in. Unsurprisingly, the leading injury in a motor vehicle collision is the person who's in a motor vehicle. And so as you can kind of see that general trend here, this is focusing specifically on who is injured and not what they collided with. But if someone's driving a car and they get into a car accident, the person who is driving the car or in the car is who is affected. And then likewise, for collided with, this is what,
Sorry, if you can go back a slide, I see other is like the second most common for the market scan. What is like encapsulated in other?
Other is basically another form of collision that wasn't necessarily described in like the data. So there's some like room for kind of a vague interpretation by putting a 9 where otherwise there would be another number. I mean, if you don't really know, like if you get a patient and you don't really know like how to code it, you can just put a 9 instead of, oh, they were in a car, or oh, they were in a bike, or something like that. And so if you're hurriedly trying to diagnose, like oftentimes you can just put 9 and that's just other type of collision that we don't really know about.
Why would there be such a large difference between the market scan other and the Medicaid other? I think that's like part of the question also.
Yeah. It might just be, I don't know, the way system and Medicaid, it might be more important to have like a more specific diagnosis as compared to a general market scan data set. But we don't know the exact reason to why there's more, I guess, vagueness in the market scan data as when it comes to who's injured.
Yeah, we also suspect that it's probably differs like hospital by hospital, state by state, etc. So it could also be those variables influencing how commonly doctors or how much time doctors will spend putting in a correct diagnosis code.
Are these codes only for the first visit, or is it also for like when people go in again? Or...
Yeah. So the way the diagnoses work is for any first visit, it has that like last A code at the thing, and then any subsequent visit is marked with a D. But it keeps the same diagnosis, except the last like code changes or not.
Right,
so any follow-up visits would be encoded with the same code, except the last letter would be, this wasn't the first time this thing happened.
The other injuries that they sustain will obviously change as they recover or discover new injuries, but these will remain constant until this whole issue is resolved.
So you just only counted the first time.
So for the initial counts, yes, but then when we look deeper into total impact, then we go deeper into subsequent follow-up visits. And then, yeah, so briefly talking about collided with, this is what the person in the motor vehicle collided with. In a car collision accident, most often, or a car collision, most often is with another motor vehicle, or in Medicaid, it's an unspecified vehicle or other type of collision. How it's coded.
So now that we've kind of explored the data and looked at the demographics, we wanted to move on to the second part, which is estimating how these actually affect people's lives. So this is about, the main metric that we used is daily disability adjusted life years. So this is a standard metric that is used by organizations like the World Health Organization or the Global Burden of Diseases Study, for example. And what it measures is adjusted life expectancy after someone has a specific injury or disability. So there are two components to this. First, you calculate the YLD, or the years of life lost and disability, and you add with it the years of life lost. So briefly, years of life lost is basically how prematurely you die compared to your general life expectancy. So suppose you get into a fatal car accident at 40, and based on your country that you live in and your gender, you would live until 78, then you would have a YLL of 38. However, for this specific project, as we mentioned, we wanted to not focus on the fatal crashes. There's a lot of literature already exists about that, and we wanted to focus on non-fatal crashes. So therefore, we did not focus on YLL in this project, and instead we were looking more at years of life loss and disability. So for one person to calculate their years of life loss and disability, for every injury, there is an assigned disability weight and recovery time, which I'll talk about in the next couple slides. So for each person, for each injury that they have, we would multiply their disability weight and recovery time and sum that up for all of the injuries they attained. So these are the disability weights. So as I mentioned, the World Health Organization and Global Burden of Diseases Study has these standard metrics that are already widely used. And the way that they get these metrics is that they have a lay description of these different injuries, and they survey the general public and ask for their opinions on how much they think this would affect someone's life. So this is on a scale from 0 to 1, with 0 being perfectly healthy and 1 being fatal. As we can see, like a long-term TBI would have like a disability weight of 0.637, so pretty severe. And then secondly, with recovery time, this will be explained a little bit further because we had 2 different approaches that we took. But yeah, so the first approach was using information from our data set and looking at reoccurring visits for outpatients and how long the patients in the hospital. And the second approach that we used was estimating recovery time from external visits. So to kind of crystallize this, we wanted to give an example. So say a patient comes in after a car crash and they have sustained a fractured clavicle and a knee contusion. So the standard disability weight for the fractured clavicle is 0.035, and the external recovery time that we found online was 49 days. So you'd multiply that to get approximately 1.72 days of YLD. Do the same for knee contusion and add them up to get the patient's total YLD of 0.0049 years. So as we mentioned, there were 2 different approaches that we took to estimating recovery time. So the first one is from our data set. So as we mentioned, there are 2 different kinds of patients, outpatients and inpatients. So for people who were outpatient, we would take their last visit day and subtract their first visit date. So for example, as we can see at the bottom, say that a patient first came in July 3rd, had a follow-up appointment July 10th and July 29th. We would assess this being the last visit by it being the last visit that had the same collision code within it. And we would say if they had a recovery time of 26 days. If they only came in for 1 visit, we would consider that a 1-day recovery time. And for people who were inpatient, there was an existing variable that included their duration of stay. So using this, we were able to calculate YLD from our data set. So as we can see, YLD tends to be pretty low. So this is a slightly zoomed out version up until 1 year lost disability. As we can see with the market scan data set and the Medicaid data set, both of them tend to cluster around 0 and kind of tend to peter out by around 0.5. The minimum was pretty small. The minimum and medium were both 1 day, telling us that most people only came for 1 visit. However, in market scans, some people had very long recovery times. For example, someone had 15 years, and the mean was around 33 days. So there's definitely patients with longer recovery times.
And then on the Medicaid side of things, these estimates seemed to be a lot lower than initially expected. Here we'll zooming in on the California Medicaid data. Will also be, since technically speaking, like all these are measured in YLD, but because that's a bit hard to understand, we're also going to talk about it in terms of days. But when we're looking at using the data set of recovery time for California Medicaid, the median's only about a half of a day of recovery time, and the mean is only about 2 days, which was much lower than we had initially expected.
Yeah, as we can see in market scan, there's definitely a similar trend of it being concentrated around 1 day. However, as we can see, the distribution is a lot tighter. In the Medicaid data set, there's still increased amount until maybe like 0.12. But here that's not really the case. And yeah, so initially we were gonna look at the state by state because we thought that would be kind of the main difference. But after looking at it, we realized that actually state by state tend to be pretty similar. So this is, don't worry about all these numbers exactly, but this is just a brief overview to show you guys that all the metrics were pretty similar for each state, which was a bit of a surprise to us. And most states still had a median of 1 day, meaning that people had very few visits. So going back to kind of this distribution, we wanted to talk more about what we think it means and our hypotheses about it. So as we can see, it's pretty tightly concentrated around 1 day, which means that most people are only having either one outpatient visit or very short inpatient stays. So considering that there's quite a bit of a follow-up issue and it's harder to track patients, this might not be representative of how long recovery actually takes. For example, if you go in with like a sprained wrist, you may not want to take the time and energy to have a follow-up visit. However, market scan, for example, also has a pretty high mean of around 33 days. So this tells us that there are many patients that are also on the opposite end of the spectrum who have quite a long recovery time. There also may be an explanation within how our data are structured. For example, in the market scan data set here, most of my data comes from outpatients who are less likely to have follow-up visits. And in the Medicaid data set, most of it comes from inpatients where it would make more sense to have maybe perhaps up to 5 days of recovery time.
But because we had kind of a variance in what market scan was talking about as opposed to Medicaid, we wanted to look at another way to potentially standardize it. And this is using external recovery times or recovery times that we found from outside sources. And so we used the same disability weights that we found from WHO data, but recovery times from external sources. So using an example, if you were in a car collision and had a coma, multiple fractures of ribs, and a fracture of a lumbar vertebrae, if you basically took the average recovery time as well as the WHO DW, you multiply those together, you sum them up, you would get that the YLD was about 0.44 years, which is about 162 days. And so kind of the result of this was it helped Medicaid at least to kind of fit more to what we were expecting, as it seemed to be a better representation of the impact or the seriousness of vehicle collision injuries. What's interesting about this graph though, is that it's sort of bimodal, meaning that as one might expect, car collisions aren't one singular beast, but rather you can have a very serious, like high impact car collision with there being a peak at around 1.5 years loss of disability. But there's also a lot of minor ones, like focusing on the larger bar that's more towards 0.
Is there a particular change that led to the 1.5 in particular?
I think the biggest change is the standardization of the recovery times, and that's something I will dive into a little bit more. But basically, because Medicaid is focusing on people of lower income, oftentimes people probably won't be going to the hospital nearly as much to represent their full time of recovery, as opposed to if we look at an injury and how long typically that injury takes to recover, then it's going to have a larger impact.
Yeah, I think the question was more about the idea that this is particularly at 1.5 that you see a bump. So is there a reason that there was a mean recovery time for one particular type of injury that might be relatively more common, which would lead to a bump particularly at 1.5? Sorry if I missed it. So it could be helpful to look into.
Yeah, that's something we can look further into, but thank you.
With market scan, we kind of see interestingly that changing it to external recovery time doesn't have as big of an effect as it did in Medicaid. So perhaps that means people were receiving similarly adequate amounts of care within market scan. And we didn't have that same issue, people having to leave the hospital as early. But yeah, so here we can see that, interestingly, something that I noticed is that, especially compared to the recovery time in our previous approach, this one also has a spike as well, whereas before it was kind of more of a regular curve going down. But still we can see here that it's still pretty tightly clustered around 1 day of recovery time. However, interestingly, our stats here are much lower than for Medicaid. So for example, our maximum is pretty similar. It's around 1,124 days. But the median and mean here is much lower than within Medicaid. And again, kind of similarly with the last one, at first we thought that state was kind of the more interesting question, but we were finding very similar trends among states. So we thought that data set by data set comparisons were more interesting. So I wanted to briefly talk about what we think that these differences represent. So despite having similar ranges, the Medicaid and the scan data sets, the Medicaid ones tend to have much higher mean and median recovery times. So this suggests to us that the average patient in Medicaid either obtains more serious injuries with longer recovery times, or they're obtaining a larger number of injuries in their collisions. And this wasn't a huge surprise to us, because to get our external codes, we looked at the top 30 most common injuries within vehicle codes, and we were actually very surprised to see barely any overlap. So to us, this is suggesting that the people in the different data sets are obtaining different kinds of injuries, which is a very interesting outcome. Another thing we noticed was that our diagnoses that tended to have longer recovery times, which might also answer your question a little bit, were more chronic conditions with things like alcohol abuse or anxiety that are probably pre-existing and like comorbid with these car crashes, and research has shown that these types of issues are already more prevalent in low-income communities. Another possible hypothesis is that they're generally in poor health due to things like nutritional factors or physically demanding jobs, and so they're more susceptible to injuries in the first place.
And then comparing our two methods of one looking at recovery from the actual data set and then looking at from external recovery data. The recovery data set sort of like fits to what the data is given, but then there's no clear way to follow up with the patient, and it's harder to actually like tell to what extent the length of the injury was once checked out at the hospital. But for external, it relies mainly on generalizations of what we would expect a typical injury to like how long a typical injury would take to recover. And so both data sets, as mentioned before, kind of behave differently with each method. So looking at the data set for recovery and for external recovery, when we look at Medicaid, there's a lower mean years lost to disability, and potentially that could be due to financial hardship or less time that is really able to be spent in the hospital. And then for external recovery, there's a higher YLD because of the perceived length of real recovery. And then also when we're looking at market scan, there's a higher mean for the data set recovery because financial hardship is less of an issue. And likewise with external recovery, it's lower because market scan is a larger data set, and so there's more variance of injuries, and so the like general like count of injuries and their overall impact are probably estimated to be lower on the external end of things. And so because of kind of the variance what we got from our different models or from our different approaches as well as our different data sets, we also wanted to look into alternative measures to being able to understand the overall impact of car collisions. These are what we wanted to look at are things known as knock-on effects, which is basically how a group or a person was affected before and after a car crash. And so we briefly looked at the total number of visits as well as money spent post-car collision injury. And so for Medicaid, we actually found that it seems that there are more often, basically we did a study of, we looked at a year before a car collision and a year after a car collision. and found that there were way more hospital visits post-car collision, not including the car collision, that happened. And so there is more of a impact on general hospital visits.
Within market scan, there were also a couple of interesting trends. First, it seems like the number of visits in general, even before a car crash, is much higher, suggesting that it's easier for these people to access care, especially with finances and time, as we've been talking about before. We do see a similar trend of there being more hospital visits after a car collision. However, we see that this difference is not as drastic as we see in Medicaid.
Another interesting thing about Medicaid is that for the Medicaid data set, spending actually increased by 36 times post-car collision than before car collision. So in conclusion, we developed new methods to look at vehicle-related codes and see what we can learn from them, as well as the diagnosis of injury. We found the scope of car collisions in state, race, gender, and age, and then also used daily to try to learn more about the extent of which these car collisions impact people.
Obviously, we really enjoyed all the work we've done so far, but we're just starting to look at these really interesting data sets and questions. So we definitely have some future steps we'd like to take. The first thing we would like to do is a matched cohort analysis, where we take people of the same age and gender and other similar factors and compare someone who has been in a vehicle crash versus not, and see kind of how their outcomes differ. Another thing we've been talking about is the Medicaid and market scan differences, and kind of hypothesizing about these, but doing some more concrete research into what is causing these differences. Also looking at inpatient versus outpatient incomes. Obviously, we can assume that people who are inpatient have more serious injuries, so seeing how that affects things. And also there's many interesting variables that we didn't have the chance to look at. So looking at the effects of those, especially ones that could be proxies for socioeconomic status. For example, within market scan, there's things like zip code that you live in, type of provider you go to, employee status, etc.
Thank you.
Any questions for the two teams? Further questions?
I think we are already running out of time, so if you have questions, talk to our fellows after the donuts. And before we wrap up, Chris, Paris, do you have any?
I just wanted to quickly thank both teams for good work. I think you guys really were the midnight oil, if I say that figuratively. So thank you, and I think that there's lots of interesting things that you have given feedback to your faculty mentors. So I think that there's scope for you to be involved in these projects. So thank you.
Thanks a lot.
Really quick reminders, return your key if you're leaving the program to myself or Lynn. For scholars, next week we are just online for our last wrap-up meeting of the summer. Respond to funding emails, those went out earlier this week by the 25th. And also, if you are leaving the program, please send us an updated bio that we can put on our website. And then congratulations on everyone, DSSG. We do have some scholars that are wrapping up the program. So there's a lot of people on that list. But I'm just saying goodbye and thank you so much.
What am I gonna do with my Wednesday now? I know. I would have forgotten.
This is the reason.